So in 2007, we recognized a need to take care of kids who do not fit a single category of care. For example, we have children with spina bifida, and they go to the spina bifida clinic where they see neurosurgery and pulmonary and plastic surgery and neurology and all of these specialists in one place. And there's the cystic fibrosis clinic, there's the hematology oncology programs, but there was no program in place for children with non-categorical conditions. In other words, a child who has multi-system disease, and that could be their GI system is involved with feeding issues and they need a feeding tube. Spasticity is involved, so they might need intrathecal baclofen therapy. Seizures, orthopedics is involved for musculoskeletal complications, and so forth. So for these group of kids, there's multiple providers in place, each one generating a system or a plan of care for the one organ system. But we did not have a place where we would wrap that around into one plan of care. So we recognized that we had an underserved population of kids that had what we term no single point of entry into a complex system. And we put together a special care program. We piloted it in 2007. It grew beyond our imagination, and in 2011 we renamed it the Comprehensive Care Program. With that change, we kind of cleaned up our criteria and had a little bit more of a definition of where we were going. And the children that we serve are in the following categories. They have chronic, complex conditions that make them medically fragile. That means they're in the emergency room a lot, they're in the hospital a lot, they're in the ICUs a lot. Medical complexity, multiple organ systems involved in their care and multiple providers involved in their care. Technology dependency, so we take care of the kids who have tracheostomies and ventilators and gastrostomy tubes and wheelchairs and all sorts of gadgets that support their quality of life and well-being. And then the fourth category is probably the fuzziest but the most important, and that's psychosocial complexity. So a child with all of this medical complexity in one setting might just glide through the system uneventfully, and another one might have lots of hiccups in their care, or go from foster care to DCFS to community placements and so forth. So the kids with psychosocial complexity are a big component of our program. What we also learned is that every child who has medical complexity, disabilities, and technology dependencies is by definition psychosocially complex. So we have a big focus on how we take care of families and integrate the family's care into our medical system of care. In our traditional healthcare system, we have a fee-for-service model. The patient comes to me, I render a service, and I get paid. So that incentivized physicians in a great level to say, come in to my office for every problem, see every specialist, because every time you touch the healthcare system, it generates more dollars. But what in the end we've done is fragmented care and drove up costs to crazy amounts of numbers. So one of the things that we looked at when we were getting ready to put this together was who are the most expensive children that we have cared for in the Intermountain Healthcare System in 2007. And then we looked back to see, were you episodically expensive or are you chronically expensive? And we found out of those 200 kids, 65% of them have neurodevelopmental disabilities, which is my area of interest. The kids with neurodevelopmental disabilities cost on average $65,000 a year over a period of 3 years. And so we did a very simple cost analysis and said, what if we took those 200 kids and reduced their hospital stay by 1 day a year? Well, the cost estimate was that we were going to save over $2 million. And so we said, all right, well, that's a good business plan. And so on we went. And then most recently, we analyzed our numbers. And we have about 550 kids in our program. We looked at how much those kids cost per child per month for the months pre-participation in our program and after participation in our program. And what we found is that each kid, average cost per member per month went down by nearly $100. Add that up over a mean of 22 months, and the total population came down in healthcare costs by over $4 million. So way beyond what we estimated in terms of our business plan. And then we dug in a little deeper. So was it $4 million for 500 and something kids? Not really. Because if we look at the kids with tracheostomies, ventilators, respiratory illnesses, if a kid comes into the emergency room with a trach or a vent and they have a fever, they're in the ICU. If a kid comes into the clinic with a trach and vent with a fever, they might have an ear infection. So it depends on the setting of care that drives our clinicians to make certain judgments. So we focused in on 75 kids with tracheostomies and ventilators. Of the $4 million savings over the 550 kids, these 75 kids amounted to $3 million in savings. So how do we do that? Do we drive this program in order to save money? Absolutely not. We drove this program to do the right thing, to give the right level of care at the right time. And that's how it's reduced costs. What do? We spend a lot of time on the phone. We do what's called Indirect Care. So families call us, they know better than anyone else how to assess their child, tell us what's going on. We make some judgments, we make some treatment plans. We might see them in the clinic, we might do phone management. And so we keep them out of the ERs, we keep them out of the ICUs. And in doing so, we've got healthier kids. Our parent satisfaction information is high. Parents, despite the complexity and disabilities of their kids, report quality of life to be really high. 80% will say good or very good or excellent. And so it just works, and it's the most logical system of care of just slow down, spend time, and listen. It's not rocket science, it's time. So now if you think about that financial model again, we talked about fee-for-service, and in the fee-for-service model, well, I'm a big loser, right? Because now what I did is I put you on the phone instead of brought you to clinic, unbillable service. I kept you out of the emergency room. The ED doc didn't make any money. We didn't get an x-ray, so radiology didn't get that. So it brings costs down, but in the end, who saves? Health insurance, payers are reaping that benefit. So that's where healthcare reform has to come in and say, all right, we need to partner with our payers, not leverage one against the other. But if we have this provider-payer-family partnership, then we're all working towards the same goal of healthcare value. Our comprehensive care program is positioned to be the center of a wheel with lots of spokes in it. And this is where we want people to enter. And that is one single phone number, or maybe two, but generally it's to the same person, the same team. We have a system of urgent messages go through to the physician team by pagers. They go to our care manager or our nurse practitioner or even to our MA. So it's team-based care, it's quick response, and it's a lot of phone management. None of this works with one person. The success of this whole process has really been the success of a cohesive team.